Welcome to Mountain Stream TV. Today's July 22nd, 2025, and I'm Ron Arps. Our mission in this series of programs is to present information about organizations and government agencies in Jackson County that provide assistance to people in our community in the areas of health, nutrition, education, and housing. Another focus of our interviews is to discuss the changes that are taking place in the way these programs operate due to funding and staffing reductions at the federal level of government. Today we have with us Marianne Martinez, the Chief Executive Officer of Vecinos. So Marianne, welcome.
Thank you.
We're very glad to see you here today.
It's nice to be here.
Let's start by having you tell a little bit about yourself and something about the history of Vecinos, and then you can talk about the mission that you have.
Okay, great. I'm Marianne Martinez. I've been the Executive Director, CEO at Vecinos since 2017, so I just celebrated an anniversary over there this summer. And we have grown a lot over the past 7 or 8 years that I've been there. We started in 2001 as a program of the Jackson County Health Department. And we worked with migrant families in Jackson County, providing primary care and social support services. The founder of the program, Josie Ellis, was a nurse at the health department, and she found a mobile clinic shortly after and incorporated as a nonprofit itself in 2004, alongside a doctor from Cashiers area, Mark Heffington. And so they worked together for many years and have always focused on Jackson County. When they incorporated as a nonprofit in 2004, they started to serve additional counties. So our biggest counties that we serve are Jackson and Macon counties. We have about 40 to 45% of our patients in those two counties every year on a regular course of any given year. And because we have such a strong focus on agricultural workers, and the biggest farms are in those two counties. I'll just kind of go over, in 2013, we became residents of Western Carolina University's campus, and so we've had an outpatient clinic on Western's campus since 2013, which has been an incredible blessing, wonderful partnership in the Health and Human Sciences building, and really deeply appreciate our partnership with Western. In 2021, as the pandemic was sort of fully underway, we happened to have to be doing our strategic planning, and our patients had seen what we had done for health education and kind of helping just provide resources during the beginning of the pandemic. And as we did our strategic planning, we asked them what they thought we should do, and they said, y'all are doing great. You need to open your services to more than just agricultural workers. And so that's what we started to work towards. So previously, our patient eligibility had been based on employment status in agriculture. And after our patients spoke up during our strategic planning process, we expanded our patient eligibility requirements to include anybody who's low income and uninsured. So a lot of people that have known us think of us as the agricultural worker, farm worker health program, which we very, very much are. That's core to our mission and who we are, our history, and always will be. And also, we serve anyone who's low income and uninsured, and an adult. We don't do pediatrics. So we just opened in May a new outpatient clinic in Franklin, in Macon County, which is our other biggest county in Western North Carolina, and we've been in there now for, going on 3 months now, so it's still pretty new to us.
It is very new.
It is. It's an 8-room clinic, 4 dental operatories, clinic or community area for people to rent or for us to have community events in. It's a massive, almost 17,000 square foot community health hub. We co-locate there with other agencies, including Pisgah Legal Services, Mountain Projects, WNC Alliance. So we have a very holistic approach to health, dental, and social health services. So that's a little bit about our history and where we are now.
Okay, great. Do you still have the the clinic here in Western?
Yes,
At
we have.
Western?
So now we have the clinic at Western, an outpatient clinic that we do every week. And we have 2 mobile clinics that go out twice a week to all of the migrant camps in the region, migrant farm worker camps. So we bring primary care, behavioral health care out to all of the migrant camps, as well as our kind of signature outreach and wraparound enabling services, and our new clinic over in Franklin.
Okay. Tell me how the mobile clinics work. Do they have a specific route that they follow, and there are different places at a certain time every week? Or
That's a great question. We have been working with our growers for many, many years. Most of them will reach out to us when their workers are about to come, or the workers will reach out directly to us and say, hey, we're in Monterey, we'll be in there, we'll be back in about a week, so that we know. We have established relationships with most every grower in the region, and the ones that have had H-2A workers or migrant workers for many, many years, we work very closely with them. So our outreach team goes first, and they do health assessments, just checking on the workers, seeing how they've been doing since they've been gone, making sure that they have everything that they may need, that the grower isn't necessarily going to provide things like toothpaste and toothbrush and socks, and making sure that they're set up for success. Moving countries for many months at a time is a hard transition, and so they need some help usually at the beginning, so we're there for that. And then our mobile clinics come and provide primary care and behavioral health care services, like I said. And then our outreach team will go back several times to do health education and social health kind of wraparound services. So we're doing nutrition, we're doing physical activity education, and then we also have health education modules that will cover everything from how to safely lift a full, bushel of apples, all the way to how to properly brush your teeth and hygiene and care. We have a huge gamut of health education modules that we cover with them.
That's great.
So, yeah, and our mobile clinics will go back several times. So we don't have like a set route, because the workers' schedules change every day. If it's raining one day, they may be home. If it's not raining, so we don't have a prescribed schedule that we follow. It's just agriculture is not predictable like that, so we have to be nimble. Yeah.
So then the mobile units are really only available to the migrant workers?
That's how we've traditionally used them. During COVID, we used them in a different way. We use them as health education, kind of rolling health education on wheels. At the beginning, we used them for vaccine sites as well. We've used them as we were waiting for our clinic to open in Franklin. We used it as an alternate site over in Franklin before our clinic had opened. So they're great resources, and we can use them as needed. But usually they're used just for the migrants. Most of that is just because of our staff capacity, though.
There was a phrase that sort of struck me when I was reading your website. It was whole patient health care. Can you elaborate on that a little more for me? I mean, you were talking about having classes and instructions and different kinds of things. Is that what whole patient health care would mean?
So I'll just use myself as an example. I am a pretty healthy person. I go to the doctor once a year, and I do my annual checkup. They do their thing. She listens to my heart. They draw blood every couple years. And I go on my merry little way. They call me and say, everything's fine. We'll see you, in a year.
Right.
And I may have other things on my mind, but I have about 10 minutes with the doctor, maybe. And beyond that, it's kind of on me to manage the system, use my privilege of speaking the language, having the ability to navigate a complicated healthcare system because I grew up in it, and know how to get anything else that I may need, social health services. If I needed, food assistance, it's on me to figure that out. If I need therapy, it's on me to figure out how to get that and how to pay for it, how to get there, find somebody who speaks my language. Again, luckily I'm a native English speaker, so it's pretty easy for me. Our patients don't have those privileges necessarily, and so that's where Vecinos really builds programs and services so that our patients are not expected to navigate an impossible system. And that's just for primary care and behavioral health care. We're also incorporating dental services into the community health hub. There's, as you probably are aware, there's a big shortage of dental services in the region. And so we're hoping to help address that with a dental partnership. And then in addition to that, it's really difficult to control your chronic disease if you're always worried about making ends meet and figuring out where can I get food that I know how to cook. When am I going to have the time to do that? And if you didn't have that very specific kind of upbringing, you don't necessarily have those skills. So that's another piece that is very adjacent and a major part of primary care that we focus on as well. So nutrition is a big piece of what we do. Physical activity also. We have exercise classes every week at the Community Health Hub as well. We have cooking classes, especially at the migrant camps. We do a lot of cooking classes. Just trying to teach folks, how to have the food that they're used to in a way that better fits their schedule. So the workers, especially the migrant workers, come home, they're hot, they're tired. There's a million people there. They get one stovetop burner for every so many people. They get one shower for every so many people. And so it's difficult to plan out your time and have time and energy to cook a meal that's nutritious and healthy. And so our team works with them to kind of develop some of those skill sets because they don't necessarily, not everybody grows up like that. So it's just another way of helping folks kind of have a healthier lifestyle. We would like for all of our patients to be well enough to never need us. And so that's always our goal. We're always trying to work ourselves out of business, right? Just like every nonprofit. So.
Sounds like you have things covered pretty well.
I hope so. We're trying. We're trying.
And are all those kinds of activities available to people who are not migrants who come into the clinics?
Yes. Anybody who's low income and uninsured and an adult, those are 3 patient qualifications. And anybody who doesn't have an existing primary care doctor or they want to transfer to us as their primary care doctor. Sometimes people will sort of hop around to different doctors, which of course is not safe medically and confusing for the medical providers. So that's another piece of patient education that we give as well.
So if somebody wanted to or to go to the clinic, what should they bring as far as meeting your qualifications?
You don't have to bring anything.
Okay.
So if a lot of our folks work and they get paid in cash, they don't have any paychecks. They don't have any proof of residence. They don't have any identification. And so if that's the case, then we do what we call attestations. And so we never want paperwork to be a barrier to healthcare.
That's great.
But it is very helpful to have it because then it can help down the line. So if we have to make a referral somewhere, a lot of times where we're referring to will require those things. For some of our funding, we have to attest that we are gathering those materials. Obviously, we don't share that material with any of our funders, but so for our internal purposes, sometimes it's better to have it. For our external purposes, a lot of times it's better to have it as well. So we do ask for it, but again, if a patient doesn't have that, we would never, deny them services.
I just read a story about a man who was on Medicaid, and he was a recovering alcoholic, and he had a lot of drugs that he had to take. And he was very diligent in getting a job and working. And he got to a point, however, where he was making too much money to continue to qualify for Medicaid. how do you, well, do you ever run into a situation like that where people kind of get to be too successful to continue coming to Vecinos, or?
That would be the dream. That would be wonderful.
Well, unfortunately, though, at that point, he couldn't afford to continue paying for his own drugs,
He
even
got
though
caught
he
in the
was
donut
just
hole.
a little bit over the
Yeah.
guidelines, you know?
Yes. So we don't accept Medicaid. We have been working towards that as a rural health center and have put the project on pause for a minute to see what happens with Medicaid and what will happen at the state level. I think we'll get into that conversation a little later. But so we haven't had an exact situation like that before. But if somebody comes to us, our patient qualification is low income, so their household income has to be at or below 200% of the federal poverty level.
Which,
So,
well, let me just say, I looked that up, and like for a single person, it's around $15,000.
that sounds right.
And so it would be $30,000 is 200%. Is that?
Something like that, yeah.
Uh-huh,
I have to
yeah.
look at the chart, but yes.
Okay.
Yeah. And so if somebody's right on the cusp of that, if we calculate and it's, just above 200% of the federal
Mm-hmm.
poverty level, we have some deductions that we can take to help things that you have to have, like a place to live, right?
Mm-hmm.
So we can, there's some allowances there that we can give. We can work with folks a little bit there. Regardless, though, if there is somebody who does have health insurance and is not considered underinsured and therefore doesn't qualify for our services, we always refer out to the local federally qualified health centers and try and work with them to either transition them over there or make a successful referral to the federally qualified health center.
So then, even though somebody's not sure if they would qualify for your services, it'd probably be good for them to come and see you anyway, and,
Oh, absolutely.
and then you could help them find something else if that was needed.
Yes, and we accept patients, as I mentioned, about the income, but also folks that are uninsured, so they don't have any medical insurance, and people that are underinsured. So some people will have something like Aflac. Oh, well, I have health insurance, so I can't go. And of course, that's not really, if you get in, it doesn't cover primary care. It doesn't cover necessarily behavioral health care. And so there's some definitions of underinsured. That's one example. Another example is if your deductible is extremely high, or if your copay is extremely high, then we consider those underinsured as well. So we have lots of charts to kind of place people and figure out where they are in these different areas so that we can really make sure we are the best fit for them. And if we're not, that's totally fine. We'll work with them, of course, to get them into a clinic that is a great fit for them. So
Sounds like you're very patient-oriented.
we are very patient-oriented.
Let's see. I guess maybe food insecurity would be something. Can you comment on how you help people who seem to be in that position?
Yes, that's a great question. We've tried a lot of different things over the years, and I will just say our partners that work in food insecurity are absolute heroes because they do some very difficult work that in a system that is not set up for their success. And so we work very closely with Manna Food Bank, the community table here in Silva, really working and empowering Mountain Food Systems, a program out of NC State University, trying to, and of course our growers as well, trying to bring in healthy food that people can learn to cook with, or that they can already know how to cook with and incorporate it into healthy meals. We really focus on budget meals and meal planning. We've partnered with Uncomplicated Kitchen in the past because having food is one thing, but knowing how to use it and cook it is another thing. Everything from knife skills to what do I do with how do I make canned tomatoes healthier, right? Canned tomatoes are very cheap. How do I actually make them a healthy option?
Mm-hmm.
And those have been really successful. I remember in one of our first collaborations with Uncomplicated Kitchen, one of our patients, she's been our patient for a very long time, cooks for a family of 4, is a housewife, and she looked at me and said, Marianne, I only just realized I never knew how to use a knife. And the woman's, 30-something years old, has 2 kids and a husband, and it was just so eye-opening for her to have those skills. And now, she's able to cook healthier meals and safer, of course, involves our kids in the cooking. And so it's those kinds of things have been really successful. But of course, having more food, in a more affordable availability is key. So we really try and focus on what food is healthy, how to cook it, how to put all of those things together with a budget meal, and then rely on our partners to bring in kind of affordable food options or free food options. We do bring food boxes out to the migrant camps typically, and then we almost always have at least dry goods available at the clinics. And also we'll have, every once in a while, we'll have somebody come out and do kind of a produce giveaway. We've done that a lot with Manna in the past.
Great.
We try. It's complicated.
Yeah, it is. I volunteer some at the community table, and I see all kinds of people coming in there that food insecurity, and I'm just so grateful that there are people who provide that food and also teach them how to use it. Is there anything else you want to say about your programs before I? Actually, there is one. Vecinos is a bilingual program.
Yes.
Right? So tell us a little more about that. Vecinos, of course, is Spanish for neighbors.
Yes, that's correct. Yes, we have. I think I did the math the other day. It was like 85 or 90% of our program staff, of all of our staff, 100% of our program staff, but 85 or 90% is fully bilingual or Spanish speaking out of our entire team. And so that includes, administration and interns. And so we really focus on having staff that can serve patients at every level and having a no wrong door approach. So lots of patients have my number and they'll call me and say, hey, Marianne, I need an appointment at the clinic. And I'll walk over to the receptionist and say, please make this person an appointment. Or they'll call me and say, I ran into this issue. Can you help me figure it out? And I get them connected with our community health workers to help them navigate the intricacies of life. And so it's really very important to us that our team can serve any of our patients at any touch point.
How many Spanish-speaking people are there in these counties? Do you have any idea?
Oh, that's a great question. The last time I looked, I think it was around 7% for Jackson County and around 10% or so for Macon County. So it's a pretty significant portion.
Yeah.
As far as the exact numbers, I wouldn't necessarily be able to tell you, though. I'm sorry.
Okay. Well, I think those percentages are pretty good.
Yeah.
So I want to ask you a question about, relating to the federal changes in funding and staffing and all, and how that might be affecting Vecinos. I saw in your list of contributors that only the USDA, Department of Agriculture, and the Appalachian Regional Commission were names that to me said, federal agencies. And so it seems like there might not be too much effect, but I'm sure there must be some. Can you comment a little bit about that and how you're coping?
Sure. So the USDA and Appalachian Regional Commission are supporters of our capital campaign. So our building is still a little bit under construction. We had some damage from the hurricane, and so we're working on that. And the USDA and ARC have come into our capital campaign. So as we built the community health hub, or I guess renovated an existing building, I should say. It seems like building to me, but We gutted it to the
Yeah.
core, all the way down, took out the beams and everything. And so it feels like a build to me, but
Right.
it's a renovation, and the project overall was about $8 million, and it's taken about 4 years to complete, from conceptualization to termination. And so the capital funds have been steady. So.
All right.
They have honored the contract. There was a moment where we were nervous about that, but they've honored the contract, and it's all working out so far, and so that's really great. We did lose a bit of funding from CDC. We have a lot of pass-through funds, so we'll work with a lot of our partner agencies. So we lost some funding from the CDC that was passed through to us by the National Center for Farm Worker Health, which is a nonprofit that's based out of Texas. And that funding was focused on COVID health education, which is extremely important for migrant farm workers because of their congregated housing settings.
I can imagine.
Yes, and so we, of course, we're still doing the work of COVID health education because it's still extremely important. It's still very contagious, and people still get COVID. And when you're down and out for several weeks, which means you are not working and you have no income. And so people coming from different countries have different levels of health education. And so between congregated housing settings and different levels of health education, it's very important that we still continue that health education for COVID. Unfortunately, we lost the funding to fund that, but we're still doing it. So there's that. The other pieces of funding have been through some of our partner agencies. We are being impacted with Office of Violence Against Women, and then some Medicaid funding as well. So again, like I mentioned, we're kind of putting on pause our look into contracting with PHPs for Medicaid, to see what happens with the unraveling of Medicaid in North Carolina and where that may or may not go. But just keep a close eye on that. And we do expect that if that does happen in North Carolina, that we will have a real influx of patients, people that are no longer insured and cannot go to their regular primary care doctors. So the safety net clinics are going to be the ones that really take the brunt of that. The federally qualified health centers, of course, will serve anybody with or without health insurance and regardless of ability to pay, but for them it will mean they have less capacity, and so they will have to kind of change their focus areas in order to make ends meet because they rely so much on Medicaid and Medicare funding. Free clinics are typically smaller and therefore a little bit more nimble than the federally qualified health centers, and so we can really pick up kind of where they're not able to. And so it's a partnership, and together we can really serve the uninsured and underinsured folks in the region.
Well, that's good to hear.
Yeah.
Yeah, I'm a little concerned about what's going to happen in the future, but you just have to carry on and
Yes.
find other ways to do things.
Yes, it's, as I'm sure you're aware, has been, especially at the state level, very controversial and honestly kind of a gut-wrenching experience and just show to watch, especially knowing how hard our representatives out here really pushed for expansion for Medicaid. And there's a free clinic in our region that is accepting it and kind of building all the infrastructure to get there, just to have kind of the rug pulled out from underneath you. It's expensive to contract with Medicaid and to start accepting insurance. And so to have put out all the capital to be able to do that and not have time to recover from Medicaid, from getting the Medicaid paybacks is difficult. The federally qualified health centers, of course, have the same issue. So yes, it's very concerning. It's very scary for our state as a whole and for our region especially.
I didn't realize there were costs like that for a provider to start accept Medicare patients, Medicaid, sorry.
Yeah, so as a free clinic, we receive free electronic health records usually from most electronic health records will have a charity side to them. And so that's what most free clinics will rely on. Once you start to bill, you have to start to pay for it, and it's costly. And in addition to billing, you also have to code the medical encounters correctly in order to get the right reimbursement. So you have to pay somebody to do that. And also, you typically also have to pay the electronic health record to help you do that a second time. So there's somebody doing it sort of for the first round, and then on another level, there's somebody also doing it. And then the electronic health record usually takes a percentage of all of that. And then there's kind of the other side of that is working with Medicaid. If there's something that has been denied, you have to have somebody who is working with Medicaid to say, okay, well, why was that denied? What do we need to change? Kind of what was coded incorrectly. So it's constant. It takes a lot of manpower. And if you have a kind of a critical mass of patients, of course, it's getting to that critical mass and making sure that it's worth the investment, I guess you could say. So it is expensive. When you build up a panel of patients, it's definitely worth it on many levels, not the least of which is you're serving patients in need. But it is expensive for the first couple of years.
All the things I don't know.
It's all of us.
Okay, let's see what else I might have here. I think that's probably all the questions that I had. Is there anything else you'd like to say?
Let's see. I will also mention we didn't talk about our focus on digital equity. So I'll just mention that really quick is
okay.
We have been, most of our migrant camps migrant farm worker camps are very far out. There's no fiber. They're not in town typically. And there's not, very much cell data because they're tucked away into the mountains. And so a lot of our migrant farm workers don't have any access to the internet, which means that they have limited communication with their folks back home, which negatively impacts mental health. Feelings of isolation and reliance on your employer can really have a big impact on your mental health. And so it's very important to us that our farm workers are able to communicate back home, and also that they can find sources of health education that are important to them. We really saw this during COVID. Having reliable sources of health education is very important. And so what we have been working on over the past probably 7 to 8 years has been trying to bring in sort of Band-Aids for digital access. We've tried hotspots at different migrant camps, which works, not great, but it works. We were very lucky to get a lot of donations of Starlink's routers during Hurricane Helene, which we've been able to install at a lot of different migrant camps so that they have great internet. And so now we're working with the growers to make sure that the growers have the resources to start sort of prioritizing this for the migrant camps as well. And so that's a big focus for us. So having access to the internet is one thing. Having devices is another thing. Most people have some form of a smartphone. And then knowing how to use that, and then knowing how to access reliable sources of information. So it's sort of a 4-prong approach to digital equity that we're working on, focusing first and foremost on our migrant farm workers, and eventually we'll scale up to where it's kind of across all of our patient populations that we're doing this digital equity focus. So just wanted to mention that because that's something that has changed in the past couple of years, especially after Helene, unfortunately, as we've gotten a little bit more resources than we would have had before.
I did think of one other thing.
Okay.
Can you use volunteers?
Oh, absolutely. Yes, we love to have volunteers. We love to have college interns. We love to have folks helping us all the time, but especially during the summer when our migrant farm workers are in town. We always need drivers, our big thing. We have 2 mobile clinics, and our staff, there's only a couple of us on staff that can drive them. So we split the responsibilities between those of us that can drive them and happily do it, but it's also really great whenever we have volunteer drivers. We need folks that can pick up our patients and bring them into the clinic or bring them to a specialist appointment. If people are bilingual, we always need interpreters, transporters, all of those kinds of things. All the way to consultants and advisors and board members. So we're always looking for folks at all levels of the organization.
All right.
Thank you for asking.
And then how can people contact you?
The best way is through vecinos.org, our website. They can always also make donations. Vecinos.org, there's a orange donate button in the top right-hand corner of the website. And on there's a contact form, and that will go to our inbox where we can kind of divvy out whoever the contact needs to be for. They can also just email info@vecinosinc.org. Come by our community health hub. There's almost always somebody there, but definitely Tuesday, Wednesday, and Thursday. We always have clinic on those days, or just giving us a call.
Okay, and is that at both clinics? Tuesday?
The Cullowhee Clinic runs only once a week. So the best, if you're going to stop by, the best place would be at the Franklin Clinic.
Okay. And we'll put up a notice on this video of all of those contacts.
Okay.
So that people can have them there when they see this video.
Great. Perfect.
Okay.
Yeah.
Well, thank you for sharing all this information with us today.
Thanks for having me. I appreciate it.
And as things progress in our changing times, maybe we'd like to have you back sometime to, talk about how things are progressing and what's changing and how to go from where we are now to where we will be then.
Absolutely. Well, Vecinos continues to grow. We're hiring a chief operating officer now, and there's no sign of slowing down. So it will, we're here to help the population in any sense that is needed at any point. We're a dynamic and flexible organization, and that's one of the many things that I love about Vecinos. Our team is very dedicated. So I'm sure that the next time we talk, there'll be lots of differences.
Okay. Well, thank you very much.
Thank you.